The third and final presentation in this session is by Dr. Drew Riddle. Drew Riddle is an assistant professor of professional practice at Texas Christian University School of Nurse Anesthesia in Fort Worth, Texas. He also serves as the director of the Center for Translational Research, a JBI Centre of Excellence. Drew is a certified registered nurse anaesthetist and maintains an active clinical anaesthesia practice. He completed his BSN at Virginia Commonwealth University, Medical College of Virginia School of Nursing, his master's with a CRNA certification, and his Doctor of Nursing practice at Texas Christian University, and his PhD is in nursing and genetics at the Medical University at South Carolina. Drew's research interests included evidence-based healthcare, pharmacogenomics, and genetic implications for anaesthesia care. Please join me in welcoming Drew Riddle.
Howdy. I'm from Texas. I apologize if there are some other Texans and Americans spread out. If you need a translation from Texan into English. I also have to acknowledge, and I apologize, because you'll look around the room and many folks from America are staring at their phones. We're actually in the middle of a presidential election. I don't know if anyone's heard of it. But as of right now, it is still too close to call. It is highly possible, as polls close now in the central part of the United States, it is now poll closing time, that while I am speaking this morning, the next president of the United States could be announced. And if that happens, Americans, please interrupt, stop, we'll make an announcement, and then drink wine. So I'm very appreciative to the organizing committee and the folks at JBI for inviting me to speak. This is my sixth JBI function, and I want to say that what attracted me to JBI in the first place was the fact that systematic reviews in JBI's eyes are for and from clinical practice. And I recognize that many of us in the room are clinicians. I myself am a clinician. Many of us are not. We're researchers or statisticians or have some other role in the systematic review process. But I think there are several folks in the room that do systematic reviews that inform policy. We have some colleagues from Africa that we've worked with for years that their systematic reviews inform policymakers, ministers of health, and health ministries and the sort. And I hear people say sometimes, well, my research, my reviews don't actually inform practice. They inform policy or economics. And I respectfully disagree wholeheartedly that whether a systematic review shows a result of an intervention in which one drug or therapy is more effective than the other, or it is at a very high level of health policy, the bottom line is that the results of that review flow through a clinician's hands and mind to impact a patient. And there is a human being at the end of 100% of what we do, 100% of what we publish. And so my talk is going to be a little bit different than my colleagues that have preceded me, in that I'm going to speak to this from the perspective of a clinician, of someone who is practicing. Myself, I practice anesthesia, but practicing and delivering healthcare, and how we as clinicians view systematic reviews, perhaps, and ways that we as systematic reviewers may involve or perhaps not involve clinicians. So this is me. This is Fort Worth, Texas. If anyone's ever been to Texas, raise your hand. Excellent. Yay. Howdy, y'all. Fort Worth is not Dallas, Texas. Our airport is the Dallas-Fort Worth International Airport, but there is a very clear line of demarcation between the two cities. My Texans will appreciate that comment. This is our skyline. Fort Worth is an absolutely beautiful city, and it's a place that I'm very proud to call home. I work at a university called Texas Christian University. We are a private, not-for-profit university. Go Frogs. The Horned Frog. Go Frogs. There's some alumni in the room and faculty, yeah. We were founded in the late 1800s. We're a rather small university by U.S. standards, just over 10,000 students, 85% of which are undergraduate students. So we don't have a huge body of graduate students. About 15% of our student body are graduate students. And we're very proud of the fact that we have a 13-to-1 student-to-faculty ratio, but we are not inexpensive. There are some TCU alum in the room that are nodding and understand that we are not. So let me say that my university requires me to put this statement that I do not have any real or potential conflicts of interest to report. I do want to tell you once again that I am a practicing clinician. I teach full-time, I practice part-time. I've been a practicing anesthetist in the U.S. for the last 16 years. And so the lens through which I view all of my work as a systematic reviewer and a researcher is that of a clinician, and it does cause a conflict of interest, both internally and sometimes with my review team. This is a picture of operating room 12 at Baylor All Saints Medical Center in Fort Worth, Texas. I took this 2 days before I flew to Adelaide. And what I wanted to show was the setup that we were doing, and I know the picture's perhaps rather difficult to see with the glare, but the setup, we were about to bring a patient in who was having an open abdominal aortic aneurysm repair. It's about a 7.5, 8-hour procedure that was complicated in the case of this patient because of multiple comorbidities. I mention it and show you what the clinical practice setting looks like because the lens through which I want you to think about your systematic review work is the person standing, which unfortunately was me this day, standing in that spot that's empty right now in front of all of those different drugs and devices and equipment, and how when we make recommendations for practice or synthesize findings at 2:30 in the morning, I may be the one that's trying to figure out what the heck to do with them and make decisions for my patient. So what I want to talk about today are 3 key points. First, what does clinical practice look like right now? How do clinicians get information, clinical information, to guide our practice? And where really is that intersection between systematic review and systematic review output and bedside clinical care, how we as clinicians use, digest, and implement that information? So, sorry, there's a little spider. He was quite distracting. I'm seeing things. It's the election. It's causing me to be, I'm really nervous about the election, not as much about speaking in front of you. I'm a little nervous. So, for those of you that have ever read anything about the U.S. healthcare system, it is by definition broken and complex, and I'm going to use the word unique because I think I'm going to be on YouTube and I don't want the U.S. government to come find me. But we really have a very interesting mix of payments, and I put the S in these parentheses because the way I am paid as a clinician in the United States is unknown to me. In all seriousness, I don't know from patient to patient who is going to actually pay me as a provider to perform an anesthetic on that patient. And it's a mix of private and public systems that sometimes work together and often do not. And like most of the rest of the world, the U.S. has gone to a pay-for-performance model. That is our new norm. And so in the United States, up until probably 5 or 6 years ago, if I delivered care, no matter how crappy that care may be, I got paid for that care. Now the U.S. payers have woken up and said, well, gosh, if I deliver really crappy care and my patient has a really poor outcome, perhaps I don't deserve to be paid what a contemporary provider may provide and actually have really high quality outcomes by whatever standards those quality outcomes are measured. And so now in the U.S. at least, we have a system where we are penalized financially for not meeting certain quality standards and benchmarks, and we are actually rewarded or incentivized for doing it right. Now, the logical question is, why don't we just do it right and pay everybody for the care they're providing? But it's the United States. So, current clinical practice, this is from the photo here, and I think it's kind of hard to see because of the reflection there, but the photo here is actually from a public domain where we publish photographic artifacts of operating room experiences. And this happens to be in Ohio at Columbus Children's Hospital, where they are performing anesthesia for the separation of conjoined twins that were 2.5 years old. And so you can see it's a very busy environment, lots of people with masks and hats. And one of the things that's interesting working in an operating room or an operating theater, is that how you say it in Australia? An operating theater, is that we don't see anything but each other's eyeballs. So think about that for a minute. All we see, we have a mask on, and we have a hat on, and we have lots and lots of clothes on because it's very, very cold. And so we get really good about looking at each other's eyes. Sandra's laughing. Sandra is my colleague from Chicago, is also a nurse anesthetist. Anybody else do anesthesia in the room? Any anesthesia folks? No? And so you get really good about looking at each other's eyes and figuring out what's happening. So you can have a whole conversation with your eyebrows. And I mention that because I want you to see a picture of the complexity in which care is delivered. The multiple layers of, unfortunately, somewhat arbitrary and sometimes real bureaucracy. Multiple agencies to which we are responsible, and that's not unique to the United States. There are multiple folks all over the world that do things to impact the decisions that we make clinically. Modern clinical anesthesia care is a highly complex field, and I don't mean to make this very anesthesia-centric, but I don't really know anything else about clinical care besides anesthesia, so you're stuck with listening to a lot about anesthesia. But what I will say, and this was borne out by Ann Wood's presentation to the Committee of Directors a couple years ago, and these are the studies to support the assertions that were made that clinicians typically have less than 30 seconds to gather, process, and act on evidence. And so, although my systematic review is clearly the best thing that's ever been written, and I would assume that you would have all read all 187 pages of it, at 2:30 in the morning when faced with a clinical decision, we really need information in a different vein, in a different venue. So how do we get clinical information as a practicing clinician? Well, just like you get your information, clearly the best place to go is Google. So we Google it. And I Google, how do I take care of this patient with this disease? And the first link that comes up is what I click on, and that obviously informs my practice, right? And unfortunately, we all say, well, clearly that's not what we do, but in reality, that is what we do sometimes. As unfortunate and misguided and uninformed as it may be, that's how decisions are made. Interestingly, as a side note, I Googled shortly before I came up on stage U.S. election results. So if you Google in Australia, connected to the Wi-Fi here, U.S. election results, the very first link that comes up is an online betting service in Australia through which you can wager on our U.S. election results. Then as you scroll down just a bit further, you get actual U.S. election results. And I say that a bit tongue-in-cheek, but again, I don't know anything about Google Analytics and where you get your website and your link on Google, but with the right finagling, the first thing that comes up when I Google could very well be the absolute worst intervention for my patient. And so the average clinician, and Ann I think pointed this out quite eloquently, the average clinician does not have time to read current evidence. So synthesized findings and the results of our systematic review may help, but they're not the answer. And our first speaker, I think, made that abundantly clear when only 3% of our 3 or 8% of our systematic reviews are actually clinically relevant. That's sort of scary. So let's think about why that is. Well, really there's two things. The first is that clinicians don't understand the process, and I mean the process of synthesis. And the second, and this was published a few years ago by my colleagues Kathy Baker and Susan Weeks out of our center at TCU, that clinicians, the average clinician can't discern quality syntheses. And unfortunately, we have low quality systematic reviews, or my very big pet peeve, artifacts that are calling themselves systematic reviews that in essence are not, being published and being portrayed as a systematic review. So what are the barriers to clinical uptake of evidence? And so they can really be distilled down, and if you have an opportunity, especially the Wallace article from 2014, this is a group out of the US, that really did a pretty exhaustive look at barriers to clinical uptake. And essentially there's four reasons why clinicians don't take up evidence. And I don't necessarily mean synthesized evidence, although there is a slant towards systematic review evidence, but really any evidence at all other than Google. And that is attitudes, knowledge, skills, and behavior. And really the piece that I think at least is rampant in the US is the third, which are skills. The ability to actually find the evidence in a meaningful way and understand then what are those findings, how do I interpret those findings, translate them into my practice in informing care for my patients. So in order to come up with synthesized findings that have some sort of meaningfulness, I've spent a long time reading and done some writing in this, but this is me. This is Drew Riddle's interpretation of what we need to have. And the practicing clinician, in order for evidence, and especially synthesized evidence, to be meaningful and useful, it needs the 3 C's. It must be concise, it must be current, and it must be contextual. And I'm going to go really, we're going to go into contextuality. Is that a word? It is now. Contextuality, or the contextual nature of this evidence here in a moment. But evidence without clinical implications is really not useful for the clinician. And my colleague Daphne Standard from the UCSF Center and I published a piece about a year ago that really spoke to this, that we can have all kinds of information, but if it has no clinical usefulness and I don't understand what to do with it as a clinician, I'm just going to disregard it. And so a great example of this, and clinical utility, something that I've spent a long time looking at and working on, and is what part of my PhD dissertation was about. And so if I, as an anesthetist, were shown an MRI of a patient's brain, the actual film of the MRI or a computer screen of the MRI of that patient's brain, I could probably tell that there were contents in the skull. But I don't, and if there were a huge tumor, I might be able to see there was something on one side that wasn't on the other. Now, the MRI in and of itself is a sensitive and specific test for whatever the reason that test was ordered, but it has absolutely no clinical usefulness, no clinical utility for me because I don't know how to read the thing. Now, if I read the radiologist's report that indicates what kind of malformation perhaps in the vasculature in the brain, well, that means something to me and it may have implications on how I plan care for that patient. So I think I want to be very clear that I'm not trying to imply that your systematic reviews, that our systematic reviews in some way are not useful. But when you think about the target audience for that systematic review, if they don't understand how the review was formulated or what those synthesized findings mean, if they don't have context, then they may be the most earth-shattering reviews or findings possible, but they have absolutely no clinical uptake because people don't understand the darn things. So where is this intersection? And as I said when I opened, I came to JBI, and what drew me to JBI, and I remember Alan Pearson speaking about this. The first JBI event that I attended was a colloquia that was hosted by our colleagues in Chicago. And I remember Alan standing up and talking about how the grounding in clinical practice was so important, and it really did resonate with me. But there is this intersection between clinicians that are performing syntheses and a synthesis that is performed for clinicians. And I think there's really a clear line in the sand between these two. And so I sort of straddle that line myself. I am a clinician, but also a systematic reviewer. And I don't mean to offend people that are pure research, and I don't mean to offend folks that are purely clinical. But what I mean is that I don't think either of us can do it without each other. And so we as clinicians bring a really strong clinical background. We really don't have any training uniquely in the methodology of the conduct of the review, but we can generate phenomenal questions. Questions that have real clinical meaningfulness and usefulness. Because let me tell you, if a clinician asks a question, they're asking it because they've just had a patient die or get injured seriously because they didn't have the answer, and we need to take that up extremely quickly. We know the context, the contextual application of the findings. Now, what do we lack as clinicians? Well, as a systematic reviewer, I have strong methodology background. I understand the process. Typically, I have excellent resources, the resources through the collaboration and everyone in this room, the resources through the Joanna Briggs Institute housed here at Adelaide, and other colleagues that do this kind of work. But I may possibly ask a misguided question. And I don't mean to be offensive to anyone in the room, but if you read some systematic reviews, both within and outside of our Joanna Briggs library, there are some really excellent systematic reviews on some of the most esoteric topics that have absolutely no clinical relevance whatsoever. And typically, if you have a team of reviewers that does not involve someone with clinical, I don't even say expertise, but at least experience, the findings are contextually void. So we have great findings that a clinician has no idea what to do with. So, excuse me, this is a picture at Baylor All Saints Medical Center in operating room 3, I believe. And you'll notice in the picture there's a gentleman. Now, the author, the people, I took this picture. The people in this picture, I know, and I blurred out their eyes, but they told me I could use it. But you'll notice there's a gentleman looking back, kind of in the middle, looking back at me taking the picture, and he's doing CPR. And there's a gentleman who happens to be a nurse anesthetist colleague of mine who has his finger up on a screen, and what he's doing is looking at a transesophageal echocardiogram of the patient's heart. This patient had a ruptured chordae tendineae and ended up with a valvular lesion that the patient expired during this care. And so what I want to point out is the context in which I might use evidence right now is very different than if I'm planning long-term care for this patient with a valvular heart disease and I want to understand his quality of life, perhaps, or long-term management of this patient for the next 10 or 15 years, as opposed to someone who is in acute cardiac arrest and we're trying to resuscitate with the same disease process. So a thorough systematic review will often miss the contextual piece. And this is even more so true for systematic reviews of effects. So when we're looking at intervention-type research, which intervention is more beneficial, useful, will cause less harm, whatever our question is, often we tend to miss the context in which that question or in which those results will be applied. So how do we involve clinicians in systematic reviews? This is Major Marvin Harrison. He is a United States Air Force certified registered nurse anesthetist. And this is copyrighted by the United States Air Force. And when you start putting pictures up of U.S. government things and you don't mention that, you can get in big trouble. So it is copyrighted by the United States Air Force. But I do have permission to use the picture. And what I want to point out is the fact that when we involve someone like Major Harrison in formulating our systematic review question, we really get some deep understanding of the question. We have clinical expertise as clinicians to drive the process. Many clinicians who haven't undergone training or have unique understanding of the methodology of the systematic review could not do it, but they really can drive and inform what we're doing. We often, as clinicians, offer very clear and practical outcomes, things that are clinically relevant and important to taking up the care of that patient and making decisions about the outcomes for that patient. We know the potential risks and harms, although we can't identify all of them. We know the ones that are really, really important for us, especially reviews of interventions or effectiveness. But I think most importantly, clinicians add the context that sometimes is missing. So when you are writing a systematic review, and I would encourage all of us to not wait until the 11th hour, 1.5 minutes before we are ready to submit the thing, and say, oh darn, I need to write the executive summary. And we all do that. You write the whole review, you go through the whole thing and you say, uh-oh, let me write this executive summary, and you throw something together real quick. For the clinician who does not have time or the knowledge to read the whole report, the executive summary, in my opinion, is the most critical part of the systematic review. I would encourage us to ground our findings and recommendations in some context that has clinical applicability. How do we do that as reviewers? We invite a clinician to be part of that review team. Because without clinical utility, the review's findings and the recommendations may be completely useless. And I don't mean to disparage the work that we do, but I think we need to think about the audience. So what are my recommendations? And I realize I'm standing between us and lunch. So I'm going to wind up quick. This is my last slide, I promise. Involve a clinician. Let that clinician lead the project, for example. We, I think, need a bit better taxonomy for our peer review process. And I've actually talked with Ed about this over the last little while as we as an organization have transitioned to a new editorial management system, which is phenomenal if you've not used it, by the way. But I think getting the right peer reviewer to review the right systematic review is critical to make sure those findings are contextually applicable. I think we all need to understand that clinical outcomes are determined because of clinical experience, and sometimes what might make sense as a research outcome may be important, but there may be a clinical outcome that is void, and without that clinical outcome, perhaps the findings of that review are less than informative, and we're not going to get the impact on care and outcomes that we need. That being said, I have been part of systematic reviews led and composed completely of clinicians, and they are absolutely terrible. They are, because they ask really great outcomes related to clinical and quality, but really have missed a big picture of things like, oh, I don't know, harm, that is just missing. So the reason I say all of this is sometimes the outcomes that clinicians want don't match what the literature says is important. And I think a systematic review that synthesizes close to nothing is as informative as a systematic review that synthesizes the findings of 20 or 30 or 40 trials. If a clinician is asked the question, it means we need an answer. If we can't answer it through a systematic review, we need to publish that, y'all. We need to say, this question's been asked, and we can't answer the darn thing. And we need to have clear guidance on what our primary reviewers need to go out and do, or primary researchers need to go out to do to generate the knowledge to answer that question. So thank you. I know it's lunchtime, so I'll be quiet now.